Hi, my name's Joanne Shaw and welcome to my presentation on multiple sclerosis. Firstly, I'll start with the presentation for this slideshow. I'll be talking about the symptoms and neuropathology of MS, the neuroscience methods used in the assessment of MS, the complexities of the diagnosis of MS, and ending with the references used for the preparation of this slideshow. So the symptoms of MS are varied. It's a disease of the central nervous system and involves the motor, sensory, visual and autonomic nervous system. So as a result, there are a number of symptoms that contribute to the condition. These include motor disorders, cognitive deficits, sensory impairments, and depression and fatigue. And they can be found in Ella Frover and Muzina in 2014 readings. These symptoms manifest differently in each person and differ in the presentation and degree. And in terms of the diagnosis, they're disseminated in different space and time. The attacks on the brain, the neurologic episodes, result in brain lesions which impact on the numerous systems and then are expressed in the numerous symptoms that are seen. It's a progressive axonal degenerative disease, and it's specifically related to the demyelination of axons and the inflammation associated with it. In terms of diagnosing MS, a number of criteria have been devised in the past 25 years, and it has been an area of contention. This is a simplified diagnostic criteria, and it's called the Barkov magnetic resonance imaging criteria. It can be found in Sakoti, 2011. So to be diagnosed using this criteria, you need to have 3 of the 4 following markers. Number 1 is the gadolinium enhanced lesions, or the presence of more than 9 T2 lesions. Number 2 is 1 fratentorial lesion. Number 3, 1 juxtacortical lesion, and 4, 1 periventricular lesion. So you can see here evidenced the areas that are involved in brain lesions for the diagnosis of MS. Here we have the phenotypes listed for MS. Because it's a disease disseminated in space and time with various presentations and various areas affected, it is classified into 3 areas of severity. So the first one is the relapsing remitting, which is the RRMS. The second one is the primary progressive, which is the PPMS. And the third one is the secondary progressive, or the SPMS. So generally speaking, most people start with the relapsing remitting form and then progress to the primary and the secondary, though sometimes some stages are missed. And figure 3, the secondary progressive, is the diagnosis that correlates to the most lesions of the brain and is closer to the end of life. And once diagnosed with SPMS, within 5 to 10 years, you're most likely to succumb to the disease. Here we have a combination of MRI and neurological PET scans. This is a brain, but it's not one person's brain. It is 5 images relating to 5 different people. And it shows you the combination of PET scans, which are the left component, for example, the left component is a PET scan and the right is an MRI scan. So used together, they can assist the diagnosis. So A, B and D are taken from a 40-year-old woman with RRMS. C is from a 25-year-old woman, which is quite rare because the age is generally 40 plus. And E is a 60-year-old woman with RRMS, and F is an RRMS 31-year-old woman. T2 or flare methods are used to diagnose MS, and you can see on the right here the image from Flockshot in 2016. This image was created after they built together this particular image from averaging 36 individuals' presentations to give a lesion burden idea of areas that are affected by MS. So FLAIR or T2 are commonly used in conjunction with MRI, and they can be used to identify demyelination. And this is also in white matter and grey matter. So this has historically been an area of contention for MS because it was initially considered a white matter disease. The weaknesses of FLAIR is that it can be lack some specificity, and there are other measures that are better long-term predictors. Functional magnetic resonance imagery is one of the most common methods used in the diagnosis of MS. It's a non-invasive method. T2 weighted scans can reveal the black holes, which are commonly recognised in MS sufferers. And one of the most recognised markers of MS is the third ventricle width, as it's normally recognised as a marker of atrophy. If you look in the image B, the two arrows are pointing to a large space. That's an MS sufferer's brain, but below you have a normal brain, and you can see the differences between the third ventricle width here. And the premise is that it's taking up space in the brain that could be used for other demands. It has been linked to cognitive deficits. The weaknesses of using fMRI is that it lacks specificity, and that's been identified in De Paulia-Ferrara in 2020. In terms of diagnosing MS, it is a complex disease, and due to the number of symptoms and the varying places in the brain where lesions take place, careful diagnosis is needed. And some other diseases show similar symptoms and also similar neurological facets. So if we look here at PML, which is the progressive multifocal leukoencephalopathy, it's generally recognised as a white matter disease of extreme immunosuppression, and for an example, an AIDS sufferer would have this, and it's as a result of a virus. And this virus destroys the oligodendrites, leading to demyelination. So here's the common factor with MS, the demyelination and the corresponding neurological deficits. But the determining factor here where that needs to be taken into consideration for diagnosis is that in MS sufferers, the lesions are monofocal, and in PML, the lesions are multifocal. So using MRI scans, you can identify where the lesions are and what type of lesions they may be. And here we have an image from Best et al. Of a brain with PML. Another condition with similar presentation as MS is neuromyelitis optica, otherwise known as NMO. It again is a demyelinating disease of the central nervous system, and the determining factor here is the oleclonal bands. MRI and FLAIR scans can be used to assist the differentiation of this diagnosis, in that whilst both MS and neuromyelitis optica have presentations of these oleclonal bands, the areas of the brain for MS are restrained to one area, and those for NMO are transient in nature. So when determining the diagnosis, scans that show these areas and this degree of damage are needed so that the correct diagnosis is given, and then the appropriate medication and therapy associated matches the condition. These are my references. I hope you've learned something about MS, and thank you very much for listening.